So the history was such that the 47-year-old male came with the chief complaint of tiredness and inability to do work over a long period of time, since 2 and 3 weeks. There was history of paralysis of left eye with eye becoming small 4 months back. Treatment for same was done with steroids. So from this
So
much
the history
history,
was such that the 47-year-old male came with the chief complaint of tiredness and inability to do work over a long period of time, since 2 and 3 weeks. There was history of paralysis of left eye with eye becoming small 4 months back. Treatment for same was done with steroids.
is
So
my
this
voice?
was such that the 47-year-old male came with the chief complaint of tiredness and
Sir, I'm
inability to
hearing
do
my
work
voice
over a long.
again.
Okay, yeah, sorry.
Yeah. Can you unmute Rohan?
Sir, I'm hearing my voice again.
It looks okay now. You can start again if
Yes, sir. So after leg, I can hear my sound again. The voice. I don't know what is the issue. Okay, sir. You may continue, sir.
no. Maybe you can unplug your headphones and try through the computer mic. Okay, so we have 47-year-old male who came with chief complaints of tiredness and inability to do work over a long period of time. Since 2 to 3 weeks, history of paralysis of the left eye with eye becoming small 4 months back.
Yes, sir.
Treatment was done with steroids. Okay.
Sir, this was in the patient's language. The history,
Okay.
the eye becoming small and everything.
Okay.
It's in the patient language.
Okay.
So yes, sir. So from the chief complainant history, it was not much of benefit. So we went ahead with the examination.
No. Wait. Is there anything else that you want to rule out or you want to ask in the history?
Yes, sir.
Mm-hmm.
Sir, I guess it's on. Yes, sir.
Yeah.
So in history of presenting illness, the weakness is gradual in onset, more towards the end of the day. That was told by the patient. It was associated with occasional difficulty in swallowing. Weakness really got to relieved after sleeping or resting and aggravated by continuous work. There is negative history of ptosis, diplopia, squint, or recent infection, systemic disease, and change in the voice.
Oh, hold on, Ron. How did you ask history of ptosis?
So ptosis, like unequalness in the eyes,
So that
aperture.
is eye becoming small, right?
Yes, sir.
That was only the chief complaint, right? And there was a history of similar thing 4 months back you
Ye-
mentioned.
Yes, sir. Yes, sir.
So then how does it become a negative history?
Sir, yes, sir.
You got my point. You
Yes,
understood what
sir.
I'm trying to point out.
Yes, sir. Yes, sir. But sir, there was no, sir, there was not clear cut for the history
You mentioned the
paralysis of the.
history of paralysis of the left eye with eye becoming small 4 months
Yes,
back.
sir. But sir, how much we can, sir, take the patient's wordings. So that's why,
No. By paralysis of the left eye, what do you mean?
sir, he was unable to move in some gazes. He was
Mhm.
unable to move the eye in some gazes.
Okay, so some ocular motility defect was there,
Yes, sir.
according to the patient.
Yes, sir. According
That's a
to.
better way of phrasing it. Like, don't mention paralysis directly.
Yes, sir.
So, patient had a history of inability to move his eye. You can mention like this 4 months back
Yes, sir.
with reduction in the size of the uh, eyelid opening, or you can say, or the eyelid, or there was history of drooping of eyelid.
Yes,
With
sir.
eye becoming small is basically drooping of eyelid. So that is how you mention that is better.
Okay, sir.
Okay. Go to the
Yes,
next
sir.
slide. Why did you ask for history of diplopia, squint, or recent infection?
Sir, as such, there are no risk factor for the myasthenia gravis. It is an autoimmune disease acquired, but there are seen some like recent infection and pregnancy, alcohol abuse can trigger it. So it can aggravate
No, no,
the myasthenia.
myasthenia is something that you have to come to the conclusion, right? Here, the patient will not tell you I have myasthenia. Patient
Yes,
is
sir.
come with complaints of what? Eyes becoming small.
Yes,
Other
sir.
than that, nothing else. Okay.
Sir, so recent infection as there was paralysis. According to the patient, there was paralysis of the eye. So there can be any uveitis, or maybe it was uveitis and patient mistook it as the patient told the treatment was done with steroid. So maybe it was the pain that was restricting the patient movement. It can be the pain.
No, unlikely. See, pain causing motility limitation is not very heard of, or rather than that, it's not very common. So, negative, see, uh, go back to your previous slide.
Yes, sir.
Okay, so basically, the patient is complaining of inability to do near work and tiredness, but there is no mention of the size of the eye or anything in his chief complaints.
Yes, sir.
Correct? So there are multiple causes. What can it's a very vague chief complaint if you see it that way.
Yes, sir.
Okay. So why do you want to directly? Why are you directly thinking in terms of myasthenia? Is my question. There are other possibilities that you have to think of.
Yes,
If
sir.
there was a history of something similar that has happened earlier in 4 months back, assuming that the light eye has become small or there is drooping of the eye. So what other causes can cause drooping of the eye?
Sir.
Drooping of the eyelid, what are the other causes that you can think of, or anybody else can take up? They are free to answer, Dr. Anuj. I mean, can they unmute? Yeah, what other causes can you think of? What
Sir.
else causes drooping of the eyelid?
Sir, if there is mm, cranial nerve third palsy.
Exactly, exactly. That is what I'm trying to make you think of. In that lines also is that is the first thing that you should think of.
Yes, sir.
Okay. So this is it could even be as per the history, it can even be a recurrent third nerve palsy. We don't know.
Yes,
Okay.
sir.
We don't know. See, history, you have not seen the patient yet. It is
Yes,
on
sir.
verbal, or you have not touched or whatever, you have not started examining the patient yet. Everything is verbal only, what we are talking and what the patient is telling us. So based on this history and the way you are describing it, the first thing that I will think of is a third nerve palsy in a 47-year-old person.
Yes, sir.
Okay, yes, this is correct that you have asked about history of diurnal variation. In your next slide, you have mentioned that.
Yes, sir.
Flip to your slide. So that is correct. That is a correct point. That's a valid point to be taken. These other points that you have mentioned, associated difficulty in swallowing, why have you asked for this?
Sir, because of the neck muscle involvement,
In
sir, in myasthenia
and
gravis.
anything else? What are the other, how is the deglutition taking place? What are the nerves involved?
Sir, deglutition. बताओ.
Any cranial nerves are involved?
Sir, glossopharyngeal nerve, cranial nerve ninth.
No, no. So basically your 9th and 10th nerve both can cause difficulty in deglutition. Okay. So
Yes,
this
sir.
you have to take a history of questions pertaining to all cranial nerves. Any difficulty in any slurring of speech? Is there any difficulty in, is there any diplopia that the patient is experiencing? Is there any loss of sensation what the patient feels? Is there any numbness on the face that he's experiencing? Is there any angle of deviation that he notices? Okay.
Yes, sir.
Any weakness in the shoulders, any weakness in turning the face here and there to the right or the left? These are the leading questions that you should ask, because I am thinking, my thinking, or rather, the first thing that will come to my mind is a third nerve palsy.
Palsy.
Okay. So then
Yes,
you
sir.
have to rule out any other cranial nerve involvement also, because that becomes more important, and the entire line of management or the entire thought process that goes on is completely different. When you are dealing with a polyneuropathy or a multiple cranial nerve involvement, when you are dealing with, the entire thought process changes.
Yes, sir.
Okay. So right now, based on this history of change in voice,
Sir, you are muted, sir.
what are the systemic diseases that you are interested in knowing about this patient? You have mentioned negative history of systemic disease, right?
Yes, sir.
So what are the key systemic diseases that you want to rule out for this patient?
Sir, diabetes is on
Exactly.
background.
Diabetes. Anything else?
Sir, and sir, multiple sclerosis, sir.
So why multiple sclerosis? Multiple
Yes,
sclerosis is
sir.
a different thing altogether. It will never present with a, yeah, Supriya has answered diabetes, hypertension, and hyperviscosity states. Exactly. And dyslipidemia. So these
Yes,
are the
sir.
things that you want to rule out, because you want to rule out an ischemic cranial nerve palsy in a 47-year-old.
Yes,
Okay.
sir.
So risk factors that can cause microischemias. So why does cranial nerve palsy occur or any sixth nerve palsy occur in a diabetic or hypertensive? It is because of the microischemia that the systemic diseases causes, which leads to ischemia to the cranial nerves, and that leads to mononeuropathy or involvement of the cranial nerve palsy. So
Yes,
these are
sir.
the important. So you have to specifically mention there is no history of diabetes, there is no history of hypertension, there is no history of any other associated, any previous, um, anything else you want to ask? Is there any other slide for history, or this is it?
Sir, there is one video, sir.
No, no, come back. That is examination. We'll come to that later. Come back.
Yes,
What else you want to ask in history?
sir. Addiction, any addiction, sir?
What addictions will cause anything like this? What addiction will cause the eye to become small? Exactly. Akila has answered. It is history of trauma.
Yes,
Okay,
sir.
trauma to the eye or trauma to the head. This is very important.
Yes, sir.
Okay, you have to rule this out. This is something that I was looking for. History of trauma is very important, especially it can cause an enophthalmos, any orbital injury. We don't know. So that is another point that is missing here. Okay,
Yes, sir.
so in your history, surgical trauma also same thing. Any previous surgeries, any orbital surgery the patient has undergone. These are some things that you have.
Things that you have.
Okay, so trauma is very important, and any history of infection, recent infections, more than recent infection, you mentioned fever. That is a more specific term.
Yes,
Okay.
sir.
So these are the, so as for the history, what we know is just that the eye is becoming small and the patient is getting tired. That's all. Other than that, we don't know anything. Okay. So fatigability, history of fatigability is not a very specific or a very reliable history, because everybody says that they get tired. Even you people must be saying that. Okay, so that is not a very specific history, but yes, it helps you to get a direction to think, is what I would say. Okay.
Yes, sir.
Lesion VKC for mechanical ptosis. Okay, but recurrent chalazion that can cause mechanical ptosis in a 47-year-old is something that is not very common. Okay, and again, if there was a chalazion and if it gets relieved, it has to either be relieved surgically or with some intralesional steroid or some intervention. Only then that the chalazion will get relieved or the ptosis will get relieved. Okay, VKC again in 47-year-old, how common is it? Not very common. Okay. So, okay, go ahead.
So this is the video. The patient.
Nobody's gonna know. Nobody's gonna know. They're gonna know. How would they know? How would they know?
Okay.
Yes,
So,
sir. So, sir, this is a fatigue test in which the patient is asked to maintain a upward gaze for 2 to 5 minutes, and after that, if there is drooping, then it is the positive test, sir. A fatigue test and eye spec test can be done in OPD.
Okay.
Yes.
Okay. So this video nicely demonstrates the fatigue test. Okay. So
Yes, sir.
how do you know that the fatigue test is okay? We'll come to fatigue test little later. Anything
Yes,
else in the examination that you want to discuss, or you want to you have any slides on anything?
no, sir.
Anything else?
No, sir.
Okay. So you did the fatigue you did the fatigue test in this patient. What else? What other tests or what other examination would you like to do in this patient? So based
So,
on our history, whatever is our thought process is that the eye is becoming small again and again, or rather the second time, okay, and the patient is getting tired. In examination, is there anything else that you want to do now?
sir, we will rule out all the other causes.
So how do you rule out?
Sir,
Let's start with third nerve palsy. Okay, that is our first differential or the first thing that came to our mind.
yes,
So
sir.
what else? What other things in history? I told you to ask for history of other cranial nerve involvement. So same way in examination, you have to examine all cranial nerves.
Yes,
Okay,
sir.
in any cranial nerve palsy case, you have to examine all cranial nerves. Okay, yeah. So pupillary reaction, extraocular movements, all these are examining cranial nerves only. Others also, right from your olfactory to your hypoglossal, you have to examine all 12 cranial nerves. That we all have done in our MBBS. Okay.
Yes, sir.
So just to brush it up, can anyone tell me how to examine the cranial nerves? Or should I start calling names? Anyone can volunteer.
Yeah, please. I think everyone can use the mic, and because
See, it's okay. You can be wrong. There's nothing wrong in being wrong. But it is worse not to try.
this is not to judge what you know. It's because you may
Or
come up with points which may not be in our mind or in sir's mind, and it will lead to a better discussion. So everyone will benefit. So I'll request everyone to use the mic, whatever little you know or something you know.
Olfactory by testing the smell with the
very
help
good.
of coffee and ammonia.
Very good.
Optic nerve by both eyes pupil reactions, direct indirect reflexes,
Very good.
and oculomotor with extraocular movements. Third nerve, fourth nerve, sixth nerve by the extraocular movements.
Very good.
Trigeminal nerve by the sensations on the face.
Yes.
And jaw jerk.
Yes. And any test you do on the cornea?
Yeah,
Cotton
corneal
waste.
sensations.
Yes, the corneal reflex test.
Yeah.
Okay. Very good. Very good, Supriya. Continue.
Okay. Facial nerve by the expressions of the facial nerve.
Yes.
And taste, anterior 2/3 of the tongue taste sensations.
Very good.
And the next vestibulocochlear nerve by this
Tuning fork test.
Weber's test.
Tuning fork, if you have, very good, but most of us don't have tuning forks in our OPD.
Then calorie test you can do by cold water.
You need not do such complicated things, or rather simple thing. What you can do is you can take a wisp of cotton and hold it near the ears and just rub it and ask the patient if he can appreciate the sound equally on both sides. That is enough. See, you just need to know grossly whether it is normal or no. See, doing the trainees or Weber's test, that is extra bonus, but you won't have that much time in your exam also to do it, nor in your clinic to do it. Okay. So you can just take a small wisp of cotton or a small tissue paper and just rub it near the ears, but simultaneously in front of both ears, and ask if they can appreciate the sound equally on both sides.
Okay.
That is enough.
Okay.
Okay. For the glossopharyngeal nerve, what do you want to see? How do you examine it?
That one. Gag reflex.
You can't gag the patient, no, in the OPD. You will puke in your OPD.
Swallowing.
No, so what you can do is you can ask the patient to protrude his tongue and say, ah, you have to look at the uvula.
Yeah.
Okay, you look for any deviation in the uvula. Okay, that is the way you look for glossopharyngeal nerve.
Glossopharyngeal.
Okay, for your 10th nerve, you ask for deglutition, any change in voice.
Okay.
That is how you know. And for your 11th nerve, you ask the patient to shrug.
Shrug. Spinal accessory.
And for 12th nerve, movement of the tongue. That is enough.
Yeah.
Okay. So any cranial nerve palsy case comes to your OPD or comes in your exam, it is important for you to mention the entire examination of all 12 cranial nerves.
Okay.
Okay, it is expected. If it is a long case, it is definitely expected. Even some examiners expect you to do a gross neurological examination also. Okay. So you have to basically look at the gait of the patient also. You have to see if there is any limping or is there any weakness in the lower limbs or upper limbs. Okay. So quickly just ask the patient to do a sit-up. That is the best thing to do. That tests all your muscles. The power in all your muscles. Okay. Yeah. So assuming all other cranial nerves are normal in this patient. Okay. And it is a bilateral involvement. Okay. So we should have myasthenia at the back of our mind. Okay. Plus he is giving history of diurnal variation, that it is more in the evening. So all these are small points that help us think in terms of myasthenia. Okay. Somebody else mentioned here of CPEO, Apurva. So CPEO is something that will be more of a constant thing. It will not be, there will be no history of diurnal variation in CPEO. Okay. Yet advanced myasthenia, the biggest differential diagnosis is CPEO. Okay. And most of the times we do get confused between myasthenia and CPEO. So the way I do it is I give a therapeutic trial for a month and see. If there is no improvement, then I work up on lines of CPEO. Okay. So coming back to myasthenia, our case. So what are the tests or what are the classification of tests, or how do you want to go ahead with this patient? You did the fatigue test. So what do you do in the fatigue test and how do you know whether it is positive or negative?
So in fatigue test, we ask the patient to hold a upward gaze and we look for the drooping of the eyelid.
How much time do you ask the patient to?
Sir, 2 minutes.
Okay. And what do you look for after 2 minutes? Drooping of the eyelid. When is it significant?
More than 2 millimeter.
Yes. So that is important. Okay. You ask the patient to look up for 2 minutes. And if there is significant drooping, we call it significant if it is more than 2 millimeters. So you measure the vertical palpebral fissure height before you start the fatigue test. Okay. Like how you do a ptosis examination, you have to do a complete ptosis examination first. So what are the things that you are supposed to see in ptosis examination?
Sir, we can do it by, sir, vaguely by the amount of the cornea. The lid is height.
I'll just tell you the points quickly. It is vertical palpebral fissure height, MRD1, MRD2, extraocular motility, LPS action, your Marcus gun jaw winking phenomena, and frontalis overaction if it is there or no. These are the things that you are supposed to see. Okay.
Yes, sir.
So if you measure the MRD1 or you measure the vertical palpebral fissure height first, then you do the fatigue test. And then if you see, yeah, Bell's phenomena, Dr. Sagrika, thank you. That is something that I speak. That is very important. In fact, Bell's phenomena is very important in examination. You want to add anything? Yeah. So you did the fatigue test. You saw that the VPFH was decreasing, or rather the drooping was increasing by more than 2 millimeters. Now it's a positive fatigue test. What is the next thing that you want to do for this patient?
Sir, as we know that myasthenia gravis is a clinical diagnosis, so we look for other things. The ocular myasthenia gravis is present in 75% initial. Is the earliest is involve the smallest muscles.
No. What do you want to do in this patient now after the fatigue test?
Sir, we can do the eye spec test, sir.
Okay. So you're supposed to do the ice pack test next. Okay. How do you do the ice pack test?
So we take eye spec and first we measure the doses, amount of doses.
Hmm.
Then we keep the eye spec for 5 minutes
Hmm.
over the eyelid, and then we reassess the doses. If
How
it is
much time do you keep the ice pack?
so 5 minutes, sir.
2 minutes.
2 minutes is enough. 5 minutes, you'll get a frostbite. Okay, so important things are, first, wrap it in a tissue paper or a small handkerchief with just one layer. Okay, don't keep the ice pack directly on the skin. If you keep an ice pack directly on the skin, it will burn the skin or it will cause a frostbite on the skin. Okay, keep it on the skin or occlude the eye. Okay, the whole point of this is to relax the muscle completely. Okay, once you do that, leave it for around 2 minutes. Ask the patient to remove it, remeasure. Okay, an improvement of more than 2 mm now is significant. Among the two, your ice pack test is more specific and sensitive than your fatigue test. Fatigue test will be positive in senile patients also. Okay, even in senile ptosis, you may get fatigue test positive. Because ultimately, when you're measuring, it is a very subjective thing. You may measure, you may get VPFH 13, I may get it as 12. You may get it as
Yes,
2
sir.
millimeter difference. I may get it as 2.5 millimeter difference, but that 2.5 millimeter need not be very specific or very significant.
Yes, sir.
Okay. So ice pack test is more sensitive than the fatigue test. Fatigue test is a very crude test that will just tell you, yeah, okay, I'm thinking in the right direction.
Yes, sir.
Okay. So these come under your office tests. Okay. There are something called as office tests. There is something called as lab test, and there is something called as interventional tests or tests that we do in the operation theater.
Yes, sir.
Okay. So in your office test, you can do only the fatigue test and the ice pack test. What are the lab tests that you want to do?
Sir, auto antibody test
Yes. Which
for
one?
N type of receptors, sir, postsynaptic receptors. Sir.
No. So what do you advise to the laboratory, or rather when you're writing and giving? So you basically write a serum acetylcholine receptor antibody test. Okay, serum ACH receptor antibody, and you do serum MuSK level, that is muscle specific kinase. Okay,
Yes,
so
sir.
these are the lab tests that you send. Other than that, what else do you send? What is the third test that you send? So you always do a thyroid function test also, because thyroid is very closely associated with myasthenia gravis.
Yes,
Okay,
sir.
so always send for a thyroid function test also. So lab test is serum ACH receptor antibody test, serum anti-MuSK antibody, that is muscle specific kinase
Kinase.
MuSK. Okay, and the third thing is thyroid function test. These are the must do in the first visit. Okay,
Yes, sir.
to get a diagnosis. Okay, other is the next one is your EMG or your muscle fiber testing.
Yes, sir. Sir,
Okay,
in this we will get a decremental response.
exactly. You will get a decremental response. So generally for ocular, we send for the orbicularis muscle.
Yes, sir.
Okay, single fiber EMG, but EMG is not that easily available to us. In bigger cities, it's more easily available. But if you are practicing in a tier 2 city, or if you're practicing in a town, then getting access to an EMG is very difficult because not many people do it. Okay. And the last thing is your neostigmine test, or that is the confirmatory test. Okay. So when you're doing the neostigmine test also, it is the same thing. You inject neostigmine intravenously and you look for a response, or you look for improvement in ptosis or diplopia. Okay, whatever is the complaint. So these are the tests, or this is how you evaluate a patient with myasthenia. So now there may be a possibility that the patient is having fatigue test and ice pack test positive, but serum ACH receptor is negative. Neostigmine is positive. Will you call this myasthenia?
Yes, sir.
Yes, this will be managed as myasthenia. Okay. So whatever lab tests are there, serum anti-MuSK or anti-ACH receptor antibodies, these have a sensitivity. Serum MuSK is sensitive in only 10% cases, whereas ACH receptor antibody may be positive in just 60% cases. 40% it is negative. Okay, so if you are in the other 40% or your patient is in the other 40%, we call it as seronegative myasthenia gravis. Okay.
Yes, sir.
So, yeah, we'll come to the significance of that later. If neostigmine is positive, the first thing is you do clinically, you check. Once clinically you feel it is myasthenia, you take the patient for neostigmine test straight away. Okay. Now, if your neostigmine test is positive, what is the next line you will do? So what I generally do is after my neostigmine test comes positive, I send the patient for ACH receptor antibody. I don't do ACH receptor antibody directly. Okay. Because there is a possibility of seronegative myasthenia. But if the patient is once the neostigmine is positive, I send for ACH receptor antibodies, I send for anti-MuSK antibodies, and after that I send for thyroid function test. I do a HRCT of the chest to look for any under associated thymoma. Okay.
Yes,
These
sir.
are the tests that I would like to do, or I do. Okay. Other than that, once the patient comes back with these reports, depending on whether the serum ACH receptor antibody is positive, you decide how to control or how long should you control continue the treatment of myasthenia. Okay. So what is the significance of serum ACH receptor antibody? I was coming to that. Serum ACH receptor antibody will just tell you, or rather if it is positive, it is just a predictor which will suggest that there is a possibility or there is a higher risk of your patient going into generalized myasthenia. Okay, the normal course of events is that the patient first will have ocular myasthenia, followed by bulbar myasthenia, followed by generalized myasthenia. Okay, are
Yes,
you
sir.
following me?
Yes, sir.
So that is how we go about it. Okay. So what did you do next in this patient?
So next, after establishing the fact that patient is having myasthenia,
Hmm.
sir, we will, sir, we will assess any, sir, the severity.
Okay, how do you do that?
Sir, if there is only ocular myasthenia gravis,
Hmm.
then we need to just start the medical treatment. If it is generalized, then we have to go do the thymomectomy also.
That is if you get something on your HRCT, no?
Yes, sir.
That's a different thing. Okay, fine. You will send the
So,
patient. Okay. You have any more slides?
sir,
Okay, yeah. You can explain this.
sir, fatigue test and ice pack test, EMG already explained by you, sir.
Hmm.
And sir, hydrophonium test or tensilon test, it is also known as tensilon test, in which we give IV neostigmine and
No,
we
no,
look.
no. They are not the same. They are different. Okay.
Yes,
Hydrophonium test we don't do in India because we don't get it here. We do only neostigmine test here.
yes,
Okay. So the Kogan lid twitch sign, what you have said is it's a clinical test. It may not be positive, but yes, it is specific for myasthenia. Okay, how do you check for the Kogan lid twitch sign?
sir. I have never performed, sir. I was unable to
Okay,
understand
yeah.
it by the
So
text.
basically, you ask the patient to look down in downward gaze
Yes, sir. And
for
then,
a period of maybe 2 to 5 minutes, and
yes,
then you ask the patient to follow your finger. and from a down gaze, you bring it to the primary gaze. Once there is a swift movement in the primary gaze, there will be a small twitch. That is, the lid will go up and then come back to the midline. That is how you see for the Kogan lid twitch sign. It is not, it is, I have just seen it in 5 to 6 patients till now. I have not seen it in many patients. But yes, it is quite specific for myasthenia gravis or ocular myasthenia. Okay. So the right way how you have to answer in your exams, okay, it is that we have office tests, we have lab tests, we have tests done in the operation theater, and we have electromyogenic or myographic tests. These are the 4 tests that is there. So in your office test, you will have to mention about ice pack test, fatigue test, and okay, even you can mention Kogan lid twitch sign, look for Kogan lid twitch sign. Then in your lab test, you have to mention about serum ACH receptor antibody, anti-MuSK antibodies, and thyroid function tests. In your test done in the OT comes your neostigmine test, and in the then comes your single fiber EMG. Okay, so this is how you are supposed to answer in the exam. Or if you get a short note also, this is the right way to mention it.
Yes, sir.
Okay. Go to the next slide.
Sir, this is the last.
Okay. Come back. Come back one more slide. Okay. Okay. History of Botox is another thing that can cause ptosis. Okay.
Yes, sir.
Okay. Okay. Akhtar Amin explain ice pack. Okay. So basically what we do is, suppose if the patient's right eye is ptotic. Okay. So what we do is we first measure the VPFH and the MRD1. Okay. Then we place a ice pack. Okay. You all have seen how an ice pack looks, right? So you take an ice pack, you roll it in a tissue paper, and then you ask the patient to place it on top of his eye. Okay. Let it be there for around 2 minutes time. After that, you ask the patient to remove it and again measure the VPFH and MRD1. If there is an improvement of more than 2 mm, that is positive. Okay. So, Rohan, shall we discuss about the management or the treatment now?
Sir, I was sir studying about the DD.
Mhm.
So I was very curious how to sir differentiate if it is early myasthenia with generalized fatigue.
I didn't get your question. Early myasthenia with generalized fatigue.
Yes, sir.
So, see, this is okay. Generalized myasthenia, you will first of all, generalized myasthenia, the patient will be much more symptomatic. Okay. You have to do an EMG of the other muscles also. Okay. That will also, you have to look for decremental response in the other muscles also. Change in voice. Change in voice is another feature. Difficulty in deglutition. These are all features of bulbar myasthenia that will come before generalized myasthenia. Okay.
No, sir. If there is sir ocular myasthenia, but in early phase,
Hmm.
and the patient is having like generalized fatigue.
See, that is a very non-specific generalized fatigue that the patient is saying. That can even be in an anemic patient.
Yes, sir.
Even if your HB is low, you can have. That is the most commonest thing that we see in India, anemia.
Yes, sir.
So even that can have generalized fatigue. That fatigue may not be directly related to myasthenia unless if the ACH receptor is positive in this patient.
Yes, sir.
If the
But
ACH
sir,
receptor antibody is positive, I am more alarmed.
yes, sir. But sir, I sometimes get in OPD a very vague complaint like आंखें भारी हो रही हैं, भारी लगती हैं.
Correct. That can
So
be even in eye strain. If your patient is an IT
yes, sir.
professional, he is working for 8-10 hours a day in the front of the computer.
Yes, sir.
Even he will have these complaints. Okay. When do you think of myasthenia or when should your brain think in that direction? Is one, if there is any concomitant squint which is unexplained, think of myasthenia. Okay. Second thing, the history of diurnal variation, ptosis on and off.
Yes, sir.
These are the two things that you have to think of myasthenia, or rather myasthenia should be there somewhere in your brain when these two things come. Okay.
Yes.
This is as such just generalized fatigueness or आंखें भारी जो patient बोलते हैं, that is not very specific of myasthenia.
Yes, sir.
Okay, and 1 minute. There are some questions in the chat box. I'll just have a look. Is it necessary to do ice pack after fatigue only? Can we skip the, yeah, you can skip the fatigue test, no problem. You can directly do ice pack. Nothing is wrong in that. But now in your residency days, if you are a resident, it is better to follow the method and do it, because if you do it now, only then it will register and only then you will be able to reproduce it in the exam. Then Dr. Sagrika has said, how do you differentiate these DDX from, what are these DDX? Can you please specify? Dr. Sagrika, can you unmute?
DDs.
Yeah, everyone, please use the mic.
No, I didn't get these DDX means what are the conditions that you are thinking, or rather you want me to differentiate from ocular myasthenia? Ptosis examination in bilateral ptosis, can you explain how to find if they are significant values? See, ptosis examination, the values.
The values are significant. That is why they're ptosis.
Yeah, I mean,
think
I didn't
they are-
understand this question also.
I think that is not for that may be a question for an oculoplastic surgeon when to operate, and
Are
that is
you
the
asking in
significance of
terms
the
of,
test.
yeah, or are you asking the normal VPFH and the MRD values? If it is not in the normal range, then it is significant. So what is the normal VPFH height? No, what I am understanding by this question is that if there is a bilateral ptosis, then how is it significant? That is what they are asking, right? Or how do you say that this is a ptosis? That is, if your MRD1 is not in the normal range, if your VPFH is not in the normal range, if it is less, then it is it is significant ptosis. They may be asymmetrical, but it is ptosis. Sir, can you please repeat tests for myasthenia? Okay, so tests for myasthenia, basically there is office tests that you do it in your clinic. That includes your fatigue test and ice pack test. Then there are lab tests in which there is serum ACH receptor antibody, anti-MuSK antibodies, and thyroid function tests. Then you have tests that are done in the operation theater, that where we do our neostigmine test. And then you have electrophysiological test, that is your EMG. Okay, differential diagnosis is Lambert-Eaton. See, Lambert-Eaton and myasthenia cannot be differentiated clinically. Okay, for that you should know what is Lambert-Eaton. Dr. Rohan,
Yes, sir.
what is Lambert-Eaton syndrome?
Sir, in EMG, in Lambert-Eaton, we will say an incremental response. Sir, the myasthenia gravis is post synaptic disease,
So,
while
exactly,
Lambert-Eaton
this
is
is a
pre.
presynaptic disease.
Yes, sir.
So your acetylcholine is not going into the synaptic cleft only in Lambert-Eaton. In myasthenia, it is there in the synaptic cleft, but it cannot come to the postsynaptic area. Okay, that is the difference. So it is at the structural level or at the that is the difference. So clinically, you cannot differentiate the two. Okay, plus Lambert-Eaton, I haven't seen any case till now. It's not that common. It is relatively rare, but yes, clinically you can't differentiate the two. Office test, lab test, electrophy. Yeah, that is.
Dr. Vishwesh, what about this non-specific sleep test? Like there are some we are seeing, I am reading in few places that you ask the patient to sleep, and do you have any experience or?
No, Dr. Anuj. That is, sleep is basically you're giving rest to the patient
Yes,
and
yes.
looking for any variation. So, I mean, we don't have that much time to do that. But yeah, I mean, in theory, yes, you can do that. So it's basically you're giving rest to the muscle. Everything, all these things are either you're provoking the muscle or you're giving relaxation to the muscle. It comes down to the same thing. So you can even ask the patient to take photographs before sleeping, or in the evening, let him take a photograph. In the morning, once he gets up, ask him to take a photograph and show you in your clinic the next day. That is another way you can do it.
So,
Sleep test while waiting for dilatation. Okay, yeah, but then after dilatation, your MRD will change, or rather your VPFH will be. You can do it while you can try it.
Get a lid retraction as well.
Yeah. Any other? Okay, so we'll quickly brush up the management part. So management
sir.
part, myasthenia is mainly medical line
Medical.
of treatment.
Yes, sir.
Okay.
Sir,
So what are the drugs that you give in myasthenia?
sir, we can give acetylcholine esterase inhibitors like
Like
pyridostigmine,
hmm?
neostigmine, and sir,
Neostigmine you don't give because neostigmine does not the half-life or
yes, sir.
it gets metabolized very quickly.
Yes, sir. Pyridostigmine longer
Yeah, so
acting, and sir,
pyridostigmine and plus pyridostigmine is available in the oral form.
yes, sir. And sir, we can give steroids, corticosteroids for adjunct, and sir, immunomodulators, immunosuppress like cyclosporin A, mycophenolate.
Okay, wait. I'll just so each of these drugs has a particular reason why you're giving. Okay, you don't give it for no reason. So myasthenia, for that you should know what is the pathophysiology of myasthenia. It is ultimately an autoimmune disease.
Autoimmune disease.
Okay, that is
Yes,
the
sir.
main crux. So there is something that is preventing your acetylcholine from reaching the postsynaptic space. Okay, or there is because of auto destruction or antibodies that are destroying. So you need to suppress the immunity. That is for that. Okay.
Yes,
Plus,
sir.
at the same time, you need to replenish your ACH levels also. So you are externally giving ACH in the form of pyridostigmine. You are not giving ACH, you are basically reducing its metabolization.
Yes, sir.
Okay, so you are increasing the amount of ACH in the synaptic cleft. Okay.
Yes, sir.
So pyridostigmine is nothing but just symptomatic treatment. Okay. The day you stop pyridostigmine, these symptoms will come back. Okay.
Yes, sir.
So whatever I was telling, I keep telling, I use a term called therapeutic trial. In therapeutic trial, I give only pyridostigmine. I don't give steroids. Okay, because you just want to see whether this is myasthenia or no. So you will just symptomatically treat it. You add steroids so that this same thing does not happen again or there is no recurrence.
Yes,
Okay,
sir.
so that is the reason you add steroid. Now, steroids are something that are short-term acting and they can be given only for a short period of time. Okay, you can't give it for a long time because
Yes,
there are
sir.
n number of side effects that steroids causes.
Yeah.
Okay,
Yes, sir.
so along with steroids, it is important for us to start the patient on something called as a steroid sparing immunosuppressant. Okay, so all these what you mentioned, most commonly what we use is azoran or azathioprine. Okay, so your azathioprine has or rather starts acting very late. Okay, it does not immediately act. You take the tablet today and it starts acting tomorrow. It doesn't happen like that. It takes some time to start acting. So till the time it starts acting, you have to give steroids. Okay. It's
Yes, sir.
something like how you give heparin before you start on warfarin, if you all remember. Okay. You give, because warfarin takes 3 to 4 days to start acting, you give heparin for the initial 3 to 4 days. So steroids is that only. Steroids is just being given for the initial sometime till the immunosuppressant start acting or till your azathioprine starts acting. Okay.
Yes, sir.
So that is the role of steroids. What are the things, other things that you are supposed to give? You are supposed to give an antacid because steroids cause a lot of acidity. And second thing that you are supposed to give is calcium supplements. Okay, because the most dreaded complication of external steroids is avascular necrosis of head of femur. Okay, your patient will have recurrent fall. He can fracture his hip very easily. That is the most dreaded complication of steroids, or because of excessive steroids, what can happen. Along with your immunosuppressants, you have to monitor the CBC for agranulocytosis, and you are supposed to monitor your LFTs, whether it is causing any liver any damage to the liver, because all these are metabolized in the liver. Okay, so every 3 monthly we get these two tests done for the patient. Okay, be careful in diabetics before starting steroids. Okay,
Yes,
it
sir.
will just make the condition worse. So if this patient had it, you have to be absolutely clear that you're not dealing with a ischemic third nerve palsy. Okay, because if it's a diabetic patient with an ischemic third nerve palsy, you think it is myasthenia, you start on steroids, you're just making it worse for the patient.
Yes, sir.
Okay, so you have to go in this stepwise manner. Okay, so the most important pearl is myasthenia. Any case of concomitant strabismus, keep myasthenia at the back of your mind.
Yes, sir.
Always rule out in any ptosis, rule out myasthenia. Do not operate the patient thinking it to be senile ptosis, and it turns out to be myasthenia. It's a nightmare later on to handle these patients. Okay. So before planning a ptosis surgery or before labeling it as ptosis, always rule out neurogenic causes of ptosis. Okay.
Yes, sir.
So anything else that you want to ask, or anybody else wants to ask anything?
If anyone has any doubt, please go ahead. Or Rohan, if you want to ask something, because you have presented this case very nicely and it has helped everyone. So actually, Rohan has also been very helpful because he's busy in his duty and he's a resident from Susrutai Foundation, Kolkata. But he's very, what we say, enthusiastic, and I this was really nice for him because it was a really great discussion. And anything else if we want to ask, because I think sir is also busy in his OPD, so we also have to let him go. If anyone has, please go ahead, or else we'll close the session, because I think myasthenia is now like we are through and through myasthenia. Now every ptosis is myasthenia for us.
Yeah, that's also not a bad way to approach ptosis. Okay, rule out myasthenia, because if it is not myasthenia, you're safe to operate.
So do we do anti-acetyl receptor antibodies in all patients and
Yeah.
neostigmine test also in all patients we suspect, like all of
Ideally,
these?
yes. Ideally, you should do neostigmine in all patients. If you don't have access to neostigmine, see, neostigmine is not at all difficult to do. Okay,
Hmm.
you just have a routine OT. If you have an anesthetist, you can do it. You should know the side effects of neostigmine. What is it? It is syncope, bradycardia, abdominal cramps, all cholinergic side effects.
Cholinergic.
Crisis.
Comes back, not crisis, but side effects or hypercholinesterase activity, cholinergic activity. So it can be done very easily. You can do it in your preoperative area also, if under the supervision of a physician or an anesthetist. It is not that difficult. However, if you're in an exclusive ophthalmic setup in a small place where you don't have access to anesthesia care, you can skip it. Okay.
Okay.
You can go directly to ACH receptor antibody test also. But again, ACH receptor antibody test is not for diagnosis. It is just to predict how much is the chance of your patient going to generalize myasthenia.
Yes.
Okay. It is it is something like how you do perimetry in, or rather, it is something like how you do OCT in glaucoma. It is not helping you diagnose it, but it is helping you prognosticate the condition. Okay. Myasthenia does come as a short note in your exam for all the residents. So yeah, do read it properly. Yes,
Sir,
go ahead.
I had one doubt. How do we do follow-up of these patients?
Yeah. So basically, what I do is I photograph all my patients. Okay. So because, or rather, if I am the only one who is checking, you have to keep a documentation of your entire ptosis evaluation, your MRD, your VPFH levels, your ocular motility, whether it is -1, -1/2, whatever it is, plus photographic documentation. In all 9 days, just take a picture of the patient. Okay. Every visit, since the patient is coming, suppose you are starting the patient on pyridoxine 60 mg 3 times a day. Okay, along with steroids, you start the patient. You call the patient again after 1 month. Generally, we space it at 1 month or 15 days, depending on where the patient is staying. Okay. On every visit, we see that only whether the lid opening is improved or no, whether the motility is improved or no. If the patient previously had diplopia, or if the patient had a squint earlier, I measure the squint. In terms of prism diopters also, you are supposed to document and see if the diplopia is reducing, or rather the squint is reducing. Okay. So these are the parameters that you are supposed to see every visit till the patient gets relief from diplopia and symptoms. Okay.
So Dr. Vishwesh, like if we get a case of squint, which is actually myasthenia, so then how do we test it? Like, will we get these ice pack tests and fatigability positive in these patients, or
no?
like,
The extraocular motility generally does not improve,
right?
Anuj. And even after neostigmine, the diplopia may not be relieved.
Okay.
But even a slight change in VPFH is a good indicator. Okay, if
Right.
you have the slightest of the doubt, if you are in the gray zone where the diplopia is not getting relieved, but you are getting some changes in VPFH
Right.
levels, always safer to give a therapeutic trial for a month.
Okay.
Give a trial of pyridostigmine for a month and see how the patient responds. Is he improving? No, or
There
not?
won't be any clinic other markers, like even investigations may not be positive if
No,
it's
they may not be positive.
Yeah.
See, if ACH receptor is positive, then there is end of discussion.
Right.
It is short, he is myasthenia. But then again, there can be a seronegative myasthenia also,
Right.
which is 40%, which is a significant percentage. We can't ignore that.
So I think if everyone is clear, no
Yes,
more
sir.
questions. If any more questions, then please put in a message, and then we'll get Dr. Vishwesh to clear your doubts.
Yeah, definitely.
And thank you, because this was really a nice discussion, and it covered all the basic from the investigations to the history and even the management part, and it was really helpful as a resident and as a practitioner as well, because these points which you have cleared, and especially the trial of management, this really helps a lot, because when we read, we see a lot of medicines, but we don't know what exactly to use. So, thank you, Rohan. It was
Thank you,
really
sir.
amazing.
Thank you,
And
Anuj, sir. Thank you, Vishesh, sir.
and this discussion is not meant to judge anyone. This is not an exam. This is just a discussion, that because if you make mistakes or if you say something, then we can discuss over it, because this is not a theory class that we'll be discussing everything about myasthenia, but whatever points we'll pick up, so that sir can elaborate, and we can pick up points which are not there in the textbook or which we cannot pick up easily. So I'll request everyone to read about myasthenia and all the tests. And if you still have any doubts, please always you can put in a message.
Thank you,
Okay.
sir.
Okay.
Thank you, sir.
It's always better to make mistakes here than your exams.
Yes.
Okay. So whatever mistakes you want, make it now. Don't make it in your exams. That's all. Okay. Well presented, Rohan.
Thank
All
you,
the
sir.
best.
Thank you. Thanks a lot, sir.
Bye.